All right. So I wanted to do a little Instagram live about how to do the setup because many of you asked me how I do it, and I thought it might be helpful to do it like this. Okay, good. So here's the approval software, and please feel free to ask questions. I will try to have a look at them and answer them. So this is a pretty straightforward case. It is a 13-year-old girl, and she wants to improve her smile. When we look at her teeth, we can see that she has some gaps in the upper jaw. We have a increased curve of spee. What else? We have some minor crowding in the lower arch. When we look at the upper arch, we also have a little bit of crowding here and some spaces. When we look at the right side, we have a class 1 molar relation in the molars and a little bit of a class 2 in the canines. I can see a lot of people are already joining. The people from Austria and Germany, they have a bank holiday, so I'm glad you spend your holiday with me. I hope you have a cup of coffee or something with you. It makes it more fun. Okay, so how I do it. First I look at the records. I already did that. I do not want to show any sensible information, so this is why I won't look at the pictures right now. So what I see here is that the arch is quite narrow, and the molar, the upper right first molar, is mesial inrotated. So I definitely want to solve this and derotate it. So I use the 3D tools that are available for Invisalign and Spark. I want to derotate it. I also want to get some expansion. So I usually do 1 millimeter of expansion in the molars. And if we look at the 7s, so the 7s usually have excessive buccal crown torque. And what we want to do is we want to get them straight. We want to have them straight. So I just use this tool right here. I will zoom in. Okay, it gets smaller when I zoom in. So here is the tool where we can rotate the tooth, and the axis of rotation will be in the middle of the tooth. I just want to show it. So here, if I use this tool, the crown will move and the root. So by using this tool, I do buccal root torque, and simultaneously I do palatal crown torque. And this is what I want to have for this tooth. So I constrict the crown and I expand the root. Like this, I get a good arch shape. So the 7s are usually flared to the buccal. So I want to reduce this flaring, and I also want to get some derotation. So like this. Okay. So I always start with the 6 and then go to the 7. I never expand the 6 to the position of the 7, but I rather constrict the 7 a little bit, adding palatal crown torque and buccal root torque, and I expand the 6 by usually 1 millimeter if I do not have a crossbite. Okay, and then I just move on forward. So in case you're wondering, I always order my setups without any changes. So I submit the scan and I write to the technician, please do not make any changes. I do this so I can do the setup myself. For me, it has shown that this saves me a lot of time because I do not need to check what has the technician done and will it be predictable, will it work out. I'd rather do it myself because this saves me a lot of time because I know where I want to move the teeth. You know, I have all the records. I know where the final position of teeth should be so that I get a beautiful smile, good occlusion, and good function. So I go further here with the 5. I align it along the arch, and I use the 6 as a reference. So I want to add some torque here. Okay, good. Then I will close the gap here. So the setup takes me usually, almost an hour to do it. For a case like this, it would take me less time. But for a complex case, it would take me about an hour to do it. But it will save me a lot of time in the long run, because treatments get very predictable like this. So after the first set of aligners, I will have almost exactly what I planned, and then I only need to do minor corrections. And the more complex a case gets, the more relevant this becomes. So here in this lateral, I have a little bit of rotation, and I want to add some more torque. All right, so I think I need some more expansion. And here are some useful key combinations that you can use to flip back and forth. On a Mac, that would be the function key. It's on the right left corner. It's the key with the word or the letters FN on it. And then you just use the arrows back and forth to switch between final and initial position. Please feel free to ask questions if there are any. I also like to use the arch form tool to check if I align the teeth along a proper arch shape. And I also use the superimposition tool a lot to see how much of expansion that I've planned. And I sometimes go back to teeth I've already moved to work on the final position. So this is usually a thing that where I'm very concentrated. So I try to speak and be concentrated at once. And actually it's a lot of fun to do it. I usually do it when I'm on a train going to work. So let's see. Okay, just by the derotation, I've probably improved the engagement. Okay, so I when I look here, I know I will need some expansion in the lower jaw as well, but we'll get to this. All right, so let's do the same in the upper, on the other side. So here, you can see that the 7 is already, the 7 is flared outside. So we'll just do some palatal crown torque and some buccal root torque. Let's look at the 6 here. It's not as badly rotated as the other side. So let's go for some expansion here. Okay. So this is how I do it. I first align the upper jaw and then I go to the lower jaw. This still looks a little bit weird here. All right. Do not have very much expansion. I have more expansion on the other side. So I want to create equal expansion on both sides because, hey, there's a comment. I love your protocols and your outcomes, but the best part is how you deliver that through your presentations. It's always great to watch your lectures. Thank you, David. You're a big inspiration for me too. Your energy and your sense for humor, I will never forget. Last time we were in Cologne and you told the joke about the Italian going to Malta. This is so much fun. All right, so any other comments are very welcome. So I was about to say how I plan movements, so I want to have equal expansion in both sides, because we always need to think of force and counter force. So if I want to expand, it's more easy to do a reciprocal movement by expanding equal amounts on both sides. All right, so let's continue here. I can always check and be very precise. So in this molar, I have 1 millimeter of expansion. You can see that here. I hope that you can see that. It says lingual buccal 1B. So 1 millimeter of buccal movement here. Let me just check that you can see my screen well. It's a little bit hard to use this kind of format. Usually I have a 16:9 screen, and now I have to smash it all into that vertical format. So let's check the other side. I have here, okay, I have a lot more expansion here, 2.2, but I also have some more derotation. So let's expand on this side a little bit more. And so this is really a learning curve. It took me several months, if not years, to be efficient with that. And I'm sure that I will get even faster and more efficient with time. But it really helps me to do even complex treatments with aligners. So let's do this here. All right, let's check the incisors. Let's remove this, we do not need that. Okay, still some rotations in incisors. Let's do it like this. Okay, looks nice. So I start with the upper arch from the occlusal. I like to use this arch form tool to to check if I have good alignment. I want to add some torque here. Okay, I think the more we do this kind of stuff, the better we train our eyes to see things. And this is the crucial thing about orthodontics. When we start, we are happy that teeth are straight, but the more we do it, the more we practice orthodontics, the more we see things like torque and occlusion and things, and we get more precise. All right, so let's look at it from the front. I want to have a nice smile arc, so I use the grid tool. And so looking at the smiling pictures, she has great incisal display, so I do not need to extrude a lot. I will just level it to the position of incisors that I already have. I want to bring the canine a little bit down here. Okay, so I use this line. So I want to have increments, steps of 0.5 millimeters. So let's check where we started. Okay, it's always easier to intrude than to extrude. So let's use this line here for the incisors. And then we do it like this here. And we make this 0.5 millimeter steps between the incisors. Like this here. So these are the little details that make all the difference. So we have a short canine here. We want to extrude it. All right, good. I like this. Let's zoom out a little bit. Okay, So I'm checking now if canines are equal. Sometimes if you have so many tools visible, it gets a little bit confusing. So I just removed the arch form tool. Okay, and I also like the superimposition tool. Helps me to avoid unnecessary movements. Like, do not need to extrude that premolar so much. Let's put the canine here on this line. It's aligned with this one, and this one needs a little bit of intrusion, and then we have a nice smile arc. All right, good. So this is not recorded, this is real time. If I fail, you will see me fail real time. No, but that's the beautiful thing about working in the software. You can always go back. To undo something, the shortcut, the key is to do Command Z. This will undo what you just did. So if you, for example, moved it in a crazy position, you just go Command Z and then it goes back. All right, so I have aligned the upper arch. Now I will take care of the lower arch. So I also want to do some constriction here in the molars because I constricted the upper arch. I also need some constriction here, not too crazy, but a little bit. I have excessive lingual crown torque in the lower arch, so this is why I'm going to upright it. And this uprighting of the crowns is a very easy movement because the aligner is touching the crown and it pushes it buccally. So the force is applied exactly where the aligner is touching the tooth, and this is very easy. Whereas when we have root movement and the aligner is touching the crown, we have a big lever, so this is more difficult. This is when I plan attachments, but for buccal crown tip or for tipping movements, you do not need any attachments because the aligner is touching the surface that we want to move. All right, so I uprighted it, and to check how much I did, I always go back and forth. All right, so also the premolar needs some uprighting and some derotation, and here as well. So what I often see in clin checks that have been done by technicians, and some doctors ask me, hey, could you have a look at this? I sometimes see that all the teeth in one jaw get extruded in order to get good occlusion, or all teeth in one jaw are intruded to avoid heavy contacts. And this is something that will not work unless you plan the anchorage. So if you need to have reciprocal movements, you need to have force and counterforce. And if you want to intrude all the teeth in one arch, for example, you would need tats to do this. Otherwise, you won't have the anchorage. Okay, so here needs some derotation here. So I imagine the arch shape in my mind, and then I align the teeth. So here, let's check this here. Okay, when I'm not talking, I'm very concentrated, so it's kind of challenging to comment everything I'm doing. I sometimes do this in private sessions with doctors who want to learn in a one-on-one call, and I move all the teeth into the software and try to explain what I'm doing. And it's sometimes a little bit hard to do things simultaneously. although I'm a woman, I'm bad at multitasking. So, for example, in the lower incisors, I want to save some time and I will move them together. So you just hold the command key pressed and then you can move several teeth together. It's just when you're working on your laptop, you press command and you will mark several items. This could be folders, and then you can move them all together. So it's the same principle that I do here. And if you look at the curve of Spee, you can see that the incisors are extruded, and it's important to intrude them because we will not be able to close the gaps in the upper incisors if we do not manage the curve of Spee in the lower arch. So we need to intrude lower incisors to be able to close the gaps in the upper arch. And also I want to get expansion in the upper arch. So I expand the posterior and retrude the incisors. So when the incisors have, for example, excessive torque, they are above 110 degrees, I want to retrude them a little bit. Easiest thing to do is to expand a little bit in the posterior, and this will create the space to retrude the incisors. But in order to be able to intrude this, in order to be able to retrude upper incisors, you need to intrude lower incisors to create the space, to create the overjet. And if we do not take care of this, we will create posterior open bite because we have an anterior pre-contact. So this is very important, and this is why many people think that aligners create posterior open bites, but really it's just anterior pre-contacts, and we can handle this. So a posterior open bite is not the end of the treatment. This is just a phase in between. We can handle that. All right, so I have done this. Good. Let's delete this gap. So this works just the same for Invisalign. You have the same tools, you have the 3D control, and you do just the same. Just checking if everything is working, looks good. So there's some irregularity in the lower incisors. I'm using the arch form tool to check how I can better align them. And you can really try this and don't expect to do a great job at the first time. So my first setups that I did were horrible, but you will get better with time. So a little uprighting here, little constriction there. And as soon as I've done the setup, I will check the occlusion. So first I do the setup, the upper arch, the lower arch, then the occlusion, and then I do the attachments and class 2 elastics if I need them. And then I tell the technician how to stage the movements. So this is the thing that the technicians do for me. They do the staging according to my orders. And I think that this is what technicians should do, because this is what they're trained for. We're trained as doctors, so we should decide the final position of the teeth. All right. Looks better now. I want to have equal expansion on both sides, so I will add a little bit here. And I check how much expansion I have by the superimposition. So you might wonder why the superimposition is blue in my Spark Approver. You can just select that. So you go to settings, then you go to appearance, and here you can do all the colors. So if you want another color, we want pink, we can just set it to pink, and voila, it's pink. So, okay, I think this will work for now. I'm checking, I'm going back and forth. I want to reduce the torque here. Great instructions, too bad my next patient is waiting. Hey Jay, so here in Austria, we're having a bank holiday, but thanks for joining anyways. Otherwise, I would be working and seeing patients too, but today I have some time to catch up with approvers and patients who are waiting for their treatment. And I thought I would just share how I do the setup with you, doing an Instagram live. So just let me know if there's anything in specific you want to hear, you want me to cover, and I will do that. Okay, good. So let's remove this. All right. Midlines are pretty much centered. I do not like the gap here between the incisors. There's some bad tipping here. Let's change that. All right, good. So now I'm checking if I like it. So this canine needs intrusion. This one as well, but just a little bit. Incisal edges are not leveled perfectly. So, okay, good. And this is why I say that I design the smile of my patients, because this is really what I do. I decide the final position of the teeth in the software, and then I make sure it comes alive in the patient. Okay, so now I'm checking if I like it. Here there could be better occlusion. Good. So let's move to the other side. Okay. Here in the canine area looks a little bit strange. Let's have a look at the Bolton discrepancy. I hope you can see that. Here, okay, mandibular axis is 1.5, and in the overall ratio it's 0.7. Okay, I wonder why this is looking so weird. So we have the edge here is cut off, and so what I like about the approval software is that it simulates also the crown. So it would be nice to do a little gingivectomy at the end to get the proper length of the canine. All right, let's see if I can improve something. So we have a crossbite here. Did I constrict too much in the upper jaw? Let's check that. Not really, didn't constrict so much. Then I will constrict in the lower arch. I will just move this here a little bit more lingual. Okay, then what I also do is I check the mesial distal movement. So this is going 0.4 millimeter mesial, and this is pretty likely because when I constrict, the tooth chooses the path of least resistance, and this is to go forward and not particularly distal. Here we have 0.2 millimeter. Okay, I think this is a pretty likely scenario, so I won't change anything about this. Then what I also check is, do I have enough overjet? Okay, so the overjet is not equal. So I have more overjet here. And if you wonder how I skip between rotation and moving the models, this is very easy. It's P to move it. I think that's called pinch. And I press the key R to rotate. So this is how I can switch back and forth very easily. And this makes looking at the models very easy. If you know that combination for the Invisalign software, please let me know, because I've been looking for that combination and I haven't found it in the Invisalign software. All right, so I want to create equal overjet. So this irregularity with the overjet can be because I didn't expand equally. Okay, here I'm moving the teeth a little bit distal. So you can see it's quite a lot of work to do the setup. But if it wouldn't save me a lot of time in the long run, I wouldn't do it. So it's really worth investing this time. And also it makes you completely independent. You do not need to text the technician what to do. Like if you want more expansion, less expansion, whatever, you can just do it yourself, and you're very efficient with it. Okay, so let's check in the lower jaw. Okay, I do expansion here and less expansion here, so I'm going to change this. To get equal overjet from canine to canine, and the overjet is really crucial. So you do not want to approve anterior contacts in software. You always want the anterior to be free of, the anterior teeth to be free of occlusal contacts. Okay, you can see it's already getting better. And this is so important to have clearance in the incisors, because otherwise it's likely to create anterior pre-contacts which cause posterior open bite. So if you have any questions, please let me know. I will try to answer them, and if I didn't see them, just keep asking them again, please, and I will try to answer them. So if you ever have too little overjet, the easiest thing is to just intrude lower incisors. This will give you more overjet, and I will show you this. So let's have a look at the overjet, how it is now. So here we have the overjet. It's not really 1 to 2 millimeters, it's far less. And now check what happens if I intrude lower incisors, how this will affect the overjet. Like this here. It seems like it's not completely leveled. Let's put the right canine on the line. Okay, now I like it. Here. So the intrusion of lower incisors is so crucial. This is why I do not get tired of mentioning it and posting about it, because This really makes all the difference. So at the end of treatment, I would take the soft flex disc and even out the incisal edges to get really nice looking teeth and making them look straight. So, okay, and now let's check the overjet again. Let's check it again, how much overjet we gained. And you can see now that we have perfect overjet. So this is what we want to have in a software. It will not look like this in the mouth. You will have less overjet. So usually you will lose like 1 millimeter. If you plan, like here I have almost 1 to 0 millimeter overjet. In the mouth I will have, I have 0 to 1 millimeter overbite. And in the mouth I will have 1 to 2 millimeters overbite. So this is why I like to do a little overcorrection here. I usually do not do overcorrections, but when it comes to lower incisors, this is a really helpful tool. When it comes to deep bite correction, I do it always. I always finish with 0 millimeter overbite. So this is what I want to have in the software to get 1 millimeter overbite in the mouth. Okay, good. Now we can check on the occlusion. Okay, we have hard contacts here. Let's check why we have those hard contacts. So I will click on the tooth and see, does it get extruded? Yes, 0.2 millimeters of extrusion. You can see here occlusal and gingival, and we will just reduce this and set it to 0. And here we go. Maybe do some intrusion. Looks a lot better here. Good. Here I'm okay with that. So let's check, let's get some more occlusal contacts. So here this one gets already extruded. How about this? Also, let's allow some extrusion here. Good. So I do not want to have occlusal contacts on the premolars because they will be intruded, because we want to level the lower curve of Spee. And if you look at here, we get a little bit of intrusion. We want a little bit of intrusion. So I've planned 0.2 millimeters of intrusion of the premolar. And if I click on this, it's even more. So here I have 0.7 millimeters of intrusion. So this is why I do not want to have occlusal contacts in the software here on the premolars, because this is very likely to end up in a pre-contact. So if you ever wondered why your patient has pre-contacts on the first premolars, this is probably because they were intruded, they got intruded, and the intrusion did not work 100%, and this is why you have pre-contacts here. Okay, good. So we did a setup of the upper arch, the lower arch. We checked the occlusion. We have still a hard contact here. Let's check. Yeah, we will intrude this some more and add some lingual root torque to get rid of these. Yeah. And you're seeing this is the new Spark software that has been released, I think, 2 days ago, which is pretty cool. We have some awesome features like the integrated hooks. I might use them here. So we started out in a class 1, but because we're expanding and retruding the incisors, I will plan some class 2 elastics just to be sure, and when I see I'm losing anchorage, then I can use them. I want to have them fabricated in the aligners, so I do not need to cut all the aligners. All right, good. So now we need the attachments, and most important attachments of all are the attachments in lower molars and premolars. So those teeth that I've just marked serve as anchorage for the intrusion of lower incisors. I'm sorry. So the 7, the 6, and the 5 are the anchorage for the intrusion of 4 to 4. This is why I need to have attachments on those teeth to avoid the aligner to lift off. So I will go to the left side and click on this feature here. So I want to have rectangular, horizontal. Let's make them 3 millimeters is okay. But in the 6, I will make it 4 millimeter. So those attachments are orange because they're either too close to the trim line, or they are they create an interference with the upper arch. Because this is a child, the clinical crowns are very small, so I cannot place them somewhere where the patient will not be biting on them, or where it will not be too close to the trim line. So I will just leave it like this. Then I will do the same thing for the other side. Voila! The attachments here are green because they are because the patient is not biting on them and it's not too close to the trim line, like here. Okay, awesome. So if we go back to the other side, and you can see that the patient will be biting on this attachment here. This is why it's marked in orange. There is a spot where there's a perfect spot for it. Cannot find it. Yeah, still, it's okay. Good, so I have now the attachments for the intrusion of lower incisors. What else do I need? I am planning some expansion in the 7s, in the 6s and 5s, and also here. So here I will plan attachments for expansion because I want to get bodily expansion. This is why I place horizontal attachments. Okay. Oh, okay, I placed them 2 times, so I just would press Command Z and remove the second set of attachments. All right, so I moved them a little bit down so they're not too close to the trim line. Here you can see how small the clinical crown is, and I need an attachment for this molar in any case, because the clinical crown is so small and the aligner is only covering the crown. So it's not a bracket bonded to the tooth. It's the aligner covering the crown that needs to deliver the force. So we need some extra retention surface. This is why I planned the attachment. Would be good to place also an attachment on the terminal molar just to get better engagement of the aligner. Let's make it a little bit smaller here. Okay, so this might cause manufacturing issues, so the design team will tell me when I submit the case if this is possible or not. Good, so I think, did we plan some extrusion here in this canine? No, we didn't, but we planned some extrusion of this canine. So this canine, let's see, where is the initial position? Okay, it gets extruded quite a bit, 1 millimeter. How are we going to make this work? Because aligners cannot extrude, aligners can only push, they cannot pull. So they cannot pull the canine and extrude it. So either we have two options to get this extrusion with aligners. First option is to do a relative extrusion, and the second option is to bond a button and have the patient wear an elastic. So let's see if we are doing a relative extrusion. So a relative extrusion would be if we have here the root and a crown, and we reduce the crown torque, like we do palatal crown torque. The root, the apex of the root stays where it is, just the crown is being extruded. And this relative extrusion works well with aligners because, again, the aligner can push, it's not pulling. A pure extrusion would be if we want to extrude the crown and the root for the same amount. So the root gets extruded and the crown gets extruded. And this is when we need elastics. So I'm checking if we have some relative extrusion here. No. So this is why I would place a button cut out here to make this extrusion possible. So here we have this. Okay, so we have a button here, and then I will place the button as close to the gingiva as possible. Because this is here a really small tooth, this means that the aligner will be rather thin here, and it tends to break, the aligners tends to break. So this is why I moved the button cutout as close to the gingiva as possible. And I need another button or hook in the lower jaw. Let's see here. Yeah, let's put it here. Just move the attachment and place a button here. I could also do cutouts, like precision cuts in the lower aligner, but it's a little bit more difficult to insert an elastic into a precision cut than just to put it on a button. And on the left side, you can see when I'm going back and forth that we retrude upper incisors, and I do not want to lose anchorage. This is why I'm going to plan hooks. And on this side, I want to try this new feature, the integrated hooks. So I will go to this integrated hook and place it here. Awesome. Wonderful. And I need something in the lower jaw. Let's put a button here on this molar. I will make the attachment 3 millimeters to fit a button here in the mesial area. Button add. Wonderful. Okay, good. All right, so I have no attachments in incisors because I do not need them. I only have the attachments where I really need them. So we will also place attachments here because we said we're expanding those teeth. Is a button better than a gingival beveled attachment for canine extrusion? This is a great question. Is a button better than a gingival beveled attachment for canine extrusion? So I would use a button whenever I have pure extrusion. I would use a changeable beveled attachment when I have relative extrusion. Again, relative extrusion is when I have palatal crown torque, when the apex of the root is not moving, but the crown is being extruded. So this is relative extrusion. And this is when I would place a changeable beveled attachment to make sure the aligner has a firm grip on the tooth and that this relative extrusion works well. In this case here, I have a pure extrusion, so also the root will be extruded, and this is why I planned the button. Please keep the questions coming. I love those. Makes me feel to be connected with you, and I love the interaction. So again, here in the molars, I need an attachment because the crown, the clinical crown, is so small, and it's hard for the aligner to pass the forces on to the tooth. All right. So, all right, so I like this. We're done with the setup. Here, maybe a little bit more of this, so it is straight. Okay, now I'm going to, so here's another question. What is the difference? What is the difference in the mechanics in using, in using a button or cutout on the canine to correct the class? Okay, this is also a very good question. And I think this case is perfectly to demonstrate it. So here on the left side, I have buttons. On the right side, I have the integrated hook and a button. And the integrated hook equals a precision cut in the aligner. So the mechanics are different in a sense that on the right side, the class 2 elastic will have more effect on the whole arch. And this is desired here because here I do not want to have any extrusion of the canine. In fact, I'm intruding the canine. So this is why I wouldn't place a button cutout on the canine, because this would be counterproductive to my intrusion. It will work against my desired intrusion. This is why I use the integrated hook here, so that when I have an elastic here, class 2 elastic, it will have a little bit of extrusive force and anterior posterior an anterior posterior vector. So I want to distribute the forces on the whole arch. This is why I plan an integrated hook here. On the other side, I want extrusion of the canine, and the only way to do it is to have a button on this. So the class 2 elastic will have the most effect on the canine and not so much on the whole arch. So this is the logic behind the mechanics between having a button or a precision cut or an integrated hook. Thank you so much for the question. All right, great. So now I will text the technician how to move the teeth. So this is pretty a very straightforward case. The technician can move all the teeth together because we have reciprocal movements. We have the expansion on both sides and simultaneously the retraction. So this is like if you imagine having a balloon, like if you constrict it in the sides, it will come, all the elastic material will come forth in the front. And this is the same, if we expand here, we can go back in the front. Thank you for sharing. I'm wondering why some attachments green and the others are orange. Would you kindly elaborate? Yes. So the attachments that are orange are the ones who are too close to the trim line and might cause manufacturing issues, or if they're interfering with occlusion. So this is a warning symbol. And when you see, okay, you have orange ones, you can tell the patient, okay, you will bite on the attachment, but this is not a problem. So in here we have the clinical crowns are so small that I cannot make them fit so they won't be too close to the trim line or won't be in interference with the occlusion. So I will not do any, let's see, okay, if teeth get distalized, no. So I do not need to leave any orders for distalization. Okay, perfect. So I think the technicians would do it correctly by default, but I will still leave a message here. Upper arch, please move all teeth simultaneously. Okay, in the lower arch, let's check what we have here. Okay, I want them to do all the movements together, all the teeth together. So I want them to constrict the sevens simultaneously with the expansion of the rest of the arch and the retraction of incisors. So this again is very straightforward. I will just do the same for the lower arch. All right, and thank you. Okay, and now I'm good to submit it. Wonderful. Okay, so now I want to take a few minutes to answer questions if you have some, so please keep them coming. It's a Spark 20 case. Thank you. No, it's not a Spark 20 case. I do not do Spark 20. I do not do Spark 10, hardly ever. Because I really want to get the most precise outcome, and this sometimes takes me several sets of aligners, and I've found that I usually pay additional aligners when I go for a Spark 20 case. Although if you want to save money, this could for sure be done with a Spark 20 case. You may have covered this, but why simultaneous as opposed to staging? So thank you for the question. I love it. I want to do simultaneous movements because I want to take advantage of the reciprocal forces. So in orthodontics, we're always looking for reciprocal forces, force, counter force. And this is why I want to move all those teeth simultaneously. Because when I'm going from this arch shape to this, I have the, maybe I can paint this to make this a little bit more obvious. So I will just paint here. So let me do some arrows here. So I have the constriction of the molars here. The sevens are going in. When we look at this here I can do the back and forth. So when you look at the second molars, I'm constricting them. So we have the same amount of force and the same direction on both sides. Simultaneously, I'm expanding here the molars and premolars. Here and here. Okay, and if you look now here in the molars and premolars, what they're doing, we're expanding them. And so here in this area, we're making the arch bigger. And we also want to make the arch smaller somewhere because it is a closed system. So we have the arch getting smaller in the posterior and also in the anterior. So this will work best if we plan these movements simultaneously all together. Okay, so when we look at this, I want to make both visible at the same time. And we check what the arch is doing. We have all these reciprocal movements, the expansion of the arch and the constriction. So the arch is getting smaller in the anteriors because we're protruding, and it's getting smaller in the sevens because we're constricting the sevens, and it's getting bigger in the sixes and premolars. And like this, we have all these reciprocal movements that we want to use. Hi, Dr. Pinter. Any tips on individual teeth not fully expressing movements tracking pathway through treatment? Oh, yes. There are a whole bunch of tricks. I just showed a few of them. Maybe you want to specify what kind of movement didn't track. So most of the times it's extrusions that would not track. The more we think of reciprocal movements and force, counterforce, and the principle that aligners can only push, they cannot pull, the more predictable our treatments get. So the more we will get exactly what we planned, and this is the ultimate goal. So the ultimate goal is to treat the most complex case with just one set of aligners, not doing any refinements. I'm not there yet, and I don't know if I will ever get there, but I'm working on it. And I also want to go back to the questions if I do Spark 20 cases. I also do not do Spark 20 cases because I have a specific retention protocol. So I do not go from active aligners, moving teeth, to retainers immediately. I do not like to do fixed retainers. I prefer the removable retainers, basically the aligners, to keep the teeth in place because patients can better clean the teeth. And so it is important not to go from moving teeth to just nighttime wear because teeth will move and get crowded again. So this is why I have like a first set of aligners with active movements, with attachments, with class 2 elastics. Then I would do another refinement to do minor corrections. I might have still attachments if it was a very complex case, or if it was an easy case, I would not have attachments. So this would be a set of aligners without attachments, just minor corrections. And then when everything is perfect, the patient has passive aligners that they wear 22 hours a day, change every 7 days, just to stabilize the tooth position. So I make a slow fade out. I do not go from active aligners to nighttime wear only. So I have a fade out procedure, and this makes it very well, and so this works really well. Thanks very much. Helpful plan. Hi, Dr. Pinto. With orange attachment, is it better to have them near occlusal plane, patients biting on them, than near trim line? I usually keep them, I just submit it, and if it's too close to the trim line and will cause manufacturing issues, the Spark design team will move them to a different position, but it's also no problem to have them close to the occlusal surface. Patients get used to it. Any other questions? I'm happy to answer them. So I hope I could explain the thing with the reciprocal movements. Something else that could be interesting, just let me know. Okay, there's another question. Just let me see it. I cannot see it yet. which software are you using? So this is Spark. This is the Spark Approver software that is the aligner brand from Ormco. Ormco, many know Ormco from the Damon system, Damon braces, and they have released their own aligner system, which is called Spark Aligners. I'm also a speaker for them, so disclaimer here. But I really like them because they allow us to also visualize the roots in a software. And I think this is necessary to do complex treatment plannings, to have also the roots in a software. Interesting retention protocol. Did you notice a significant difference to what you used to before? Well, I used fixed retainers before, and of course fixed retainers work perfectly. What I do not like about fixed retainers is that it's only from canine to canine, and patients cannot clean it very well. But yeah, fixed retainers are wonderful. I just do not like them. I do not like them. Doctor, in your opinion, conventional or optimized attachments? Greetings from Colombia. I loved your Instagram live. Thank you so much. Greetings back to Colombia from Vienna. Please let me know where you're from. I love that. I love the feeling to be connected all over the world. So the question was conventional and optimized attachments. I like to use conventional attachments because I like to keep things as easy as possible. And if you have attachments that are rectangular, they're so easy to fill. So I fill the attachment template with hard composite because flowable composite wears too easily, too quickly, and you get all these air bubbles that end up in food traps. So I like to use conventional attachments because they're easy to fill, they're easy to remove the excess around them. And it is said that with the optimized attachments from Invisalign, that they're designed so that the aligner is only touching the optimized surface of the attachment. But what we really want is the aligner to cover all of the tooth, to get as much engagement of the aligner with the tooth as possible. And this is also what is different about Spark aligners than with Invisalign. The Spark aligners are fabricated on a model that is printed with higher resolution so that the aligners are more clear, they're more invisible, and they also are contacting with a bigger tooth surface. They have more contact with the tooth surface. What's your opinion on overcorrection? So I'm not a fan of overcorrection because it makes treatments more complex. And as I said, I want to keep things simple. Simple is good. With overcorrection, you never know how much overcorrection is enough to get the desired result. So the only time I do overcorrection is with intrusion of lower incisors. I plan 1 millimeter of overcorrection because teeth are in the bone with a periodontal ligament, and if you intrude them, you also stretch a little bit the periodontal ligament and wants to bounce back, and you will get this little bit of rebound and relapse effect. So this is why I do 1 millimeter of overcorrection. In which cases do you use TADs, and where is the border to use them or not to use them? Thank you for the question. I use TADs when, for example, if I want to intrude more than 2 millimeters, for example, I want to do posterior intrusion, and so intrusion of several teeth might be possible up to 1 millimeter. If it's just a single tooth, 2 millimeter is also possible. But if you have like a patient that is missing the lower dentition and you want to intrude upper teeth that are over erupted, I would go for TADs. I use TADs in adults because in children the bone is softer. So in children everything is easier than in adults. So this is why I mainly use TADs in adults. Thanks from Chile. Hi to you in Chile from Vienna. Thank you so much. Thanks for answering questions. Someone from India wrote. So glad to have people from India here as well. Hi everyone. Yeah, hi Pedro, you're also joining. That's awesome. Great to have so marvelous orthodontists here in this live as well. Okay, so last opportunity for questions. Otherwise, I'm wishing you all a nice Tuesday and a nice bank holiday if you're in Austria or Germany. Is there anything I still need to cover? I think that was it. So thank you so much for joining. I think we will do that more often. I was fascinated about the people who joined me because this was completely unannounced and completely spontaneous. It was a new thing for me to do. I just wanted to try it, and please let me know if it was helpful or how can I make it more helpful for you. Just write me a direct message and I will make sure to make it work in the next session. So have a great day. Bye.